Welcome to the Drive-In Prenatal Screening and Diagnosis Theater. Looks like there's a 2-for-1 deal tonight, and we've gotten here just in time to catch the show. So, buckle up and silence your horns. It looks like the movie's about to start. Prenatal screening and diagnosis tests help us determine if the fetus is at risk of or has a disorder due to a genetic cause before the baby is born. These tests should be offered to every pregnant woman regardless of age or ethnicity. So why do prenatal genetic testing? There are so many reasons. Many families want to understand if the fetus has any known disorders that may interfere with viability and/or quality of life. Similarly, patients who have a known family history of a disease may want to know what the chances are of having an offspring with the disease, or if they've already conceived, if their offspring is affected. Finally, for the obstetric and pediatric teams, it's extremely helpful for delivery and perinatal planning to understand the potentially complicated anatomy and physiology of a newborn if they have a known disorder or syndrome that may affect their ability to thrive immediately postpartum. In order to fully understand prenatal screening tests, we must first distinguish between screening tests and diagnostic tests. Genetic screening tests, which we're going to symbolize on these 2 gigantic movie screens, determine if there's an increased risk of the fetus having a genetic disorder. The most common genetic screening tests screen for fetal aneuploidies, such as Down syndrome. It's very important to counsel a patient on what a screening test is prior to doing one because she and her family must understand that a positive result on a screening test does not mean that her fetus is affected by the disorder being tested for, only that the fetus is at an increased risk for having this disorder in comparison to the general population. If the patient does have an increased risk on any of the screening tests, she's then offered diagnostic testing, which will determine whether a disorder is present, to the extent that the test used can be certain of diagnosis. The most common prenatal genetic screening tests used in the United States screen for aneuploidies, and every woman should be offered these tests. We'll first go over the trimester-specific tests and their components, and then talk about how they're used alone and in combination with each other to come up with a final risk assessment. The first trimester screen, which we'll conveniently portray here on screen 1, consists of 2 parts, maternal serum analytes and an ultrasound. Both of these are performed between 11 and 13 weeks gestational age, and the results show whether or not there's an increased risk for trisomy 21 and trisomy 18, also known as Down syndrome and Edwards syndrome, respectively. This movie on screen 1 is all about Papa Christmas and his handy helper in the beta glasses, because serum analytes tested for are PAP-A, which stands for Pregnancy-Associated Plasma Protein A, and our old friend beta-HCG. This is a rollicking family film in which our dynamic duo is delivering a sack of toys to all the boys and girls. Those kids want to know what they're getting, though, so that sack is translucent. Wonder why. Must be because the ultrasound component looks for and measures nuchal translucency, which is a fluid-filled space that can be measured at the back of the fetal neck. If the nuchal translucency, or NT as it's more commonly referred to, is greater than 3 millimeters, then the fetus has an increased risk of aneuploidy or structural malformation regardless of the results of the serum analytes. Notice that there are 3 ultrasound waves coming out of Papa Christmas's bullhorn. If the first trimester screen shows that the fetus is at high risk for one of these conditions, you can proceed to cell-free DNA testing for further risk assessment or chorionic villus sampling or amniocentesis for diagnostic testing. Don't worry, we'll go over each one of these a little bit later in this sketch. Let's head on over to screen 2 and see what goes on during the second trimester. During the second try, you can do a screening test known as the quad screen, which assesses the risk for trisomies 18 and 21, as well as for neural tube defects and abdominal wall defects. This test is done between 15 and 22 weeks and looks at 4 maternal serum analytes, beta-HCG, maternal serum AFP, estriol, and inhibin A. Each disease that's being screened for has a specific pattern of analyte levels that you may be asked to recognize. One way to remember all of these is just to remember one unique level for each disease. For trisomy 18, everything is low. Trisomy 21 has high HCG and inhibin A, and neural tube and abdominal wall defects have high AFP. So this is what's playing on screen 2 tonight. In trisomy 18, all the analyte levels are low, which is why the refrigerated, get it, Edwards syndrome? 18th car of this train is falling down off of this cliff. In trisomy 21, AFP and estriol are low, while HCG and inhibin A are elevated, So this train conductor with 21 tickets is holding his beta glasses high up in the air, and the sign of this elevated A-shaped stoplight says we're heading downtown, one of our recurring symbols for Down syndrome. Man, this conductor probably should have paid attention to that red light. For neural tube and abdominal wall defects, only AFP is elevated. So this tube-shaped train car is throwing Alf's produce high up in the air. Now comes the tricky part, using the first trimester and quad screen together to get results. You're going to hear many phrases thrown around, such as integrated screen, serum integrated screen, and sequential screening. The most important thing to know to understand all of these terms is that all of them deal with the first trimester screen and quad screen in some combination. They are not separate tests from the first tri and quad screens. Rather, they use components from each to perform a risk assessment. This can be pretty confusing, but let's go over each now. And as you'll see, the name for each combination of tests actually makes sense. The integrated screen is both the full first trimester screen, including the NT measurement, and the quad screen. When these results are pooled, the Down syndrome detection rate is 96%. Pretty good. The serum integrated screen is the first tri screen without the NT measurement plus the quad screen. This makes sense from the name as it only takes into account the values obtained from the maternal serum. Its Down syndrome detection rate is 88%. With either of the integrated screening options, a result is not given to the family until the completion of a second trimester screen. Many families will want to know earlier than the second trimester if there's an increased risk for an abnormality, especially because so many states restrict terminations to the first trimester. This is where sequential screening comes in. Sequential screening allows the results of the first trimester screen to be known, and if the result is low risk, you would proceed to do a second trimester screening. If the result of the first trimester screen is high risk, then you would continue on to cell-free DNA testing or diagnostic testing. We keep mentioning this thing called cell-free DNA testing, and we haven't explained it yet. It's the test with the best detection rate for Down syndrome at 99%, so it's important to know about. Plus, many patients will request this test because it's the earliest way to find out the fetal sex. Cell-free DNA testing is also called the NIPT, or NIPS, symbolized by our recurring symbol, free nipples, which stands for non-invasive prenatal test or screening. What can be confusing is that cell-free DNA testing can be done as early as 10 weeks, which is in the first trimester, but it is not what's being referred to when people speak of the first trimester screen. The cell-free DNA test tests for 3 trisomies, 13, 18, and 21, and will also tell you the fetal sex. It does this through a combination of counting and sequencing fragments of fetal cell-free DNA that's found in the maternal blood. This test is important because of how early you can do it, that it tells you the fetal sex, and that it has the highest detection rate for Down syndrome at 99%. Unfortunately, cell-free DNA testing can be pretty expensive, and it's not as widely available as the first trimester and quad screens. Some people choose to pay for this out of pocket, but there are a few indications to recommend cell-free DNA testing in place of the first tri and quad screens. These are any abnormal screening test, advanced maternal age 35 or above, an abnormal anatomic finding on ultrasound, a previous pregnancy with fetal aneuploidy, or a known parental balance translocation, such as a Robertsonian translocation. On this menu, we've arranged the tests from cheapest to most expensive. Worst Down syndrome detection rate to best. As you can see, the quad screen alone has the worst at 81%, and the cell-free DNA has the best at 99%. The final thing we'll say about maternal serum genetic screening is that the most common reasons that you may get wrong results are poor dating and multiple gestations. Hey, you quadruplets, pay attention to the movie. It's high yield. We've talked about screening the fetus. Now let's talk about another type of prenatal screening that assesses whether the parent carries any genes for any known, usually autosomal recessive, disorders. This is called carrier screening and is ideally done once because the results won't change. First, test the mom, and if she's a carrier for a disease, you can then test the genetic father. Here we'll cover the diseases most commonly tested for and indications to recommend certain tests. Carrier screening for spinal muscular atrophy, symbolized by the spiny tree trunk, and cystic fibrosis, symbolized by these sappy branches, should be offered to every pregnant woman as these are easy to test for and are diseases with devastating consequences. If a patient's baseline CBC shows anemia and she's of African, Mediterranean, Middle Eastern, or Southeast Asian descent, then you should offer hemoglobin electrophoresis to screen for hemoglobinopathies, which include sickle cell disease, alpha thalassemia, and beta thalassemia. Sometimes you'll be asked to interpret a hemoglobin electrophoresis, so we'll briefly go over the findings for each of these hemoglobinopathies here. As you may remember, patients with the sickle cell trait or disease have hemoglobin S, which is a mutated beta globin. Those with 2 mutated globin genes have full sickle cell disease, symbolized by this horror movie, The Sickle. These patients' hemoglobin electrophoresis will show a lot of hemoglobin S and no normal hemoglobin A, because there are no normal beta globins to make it. For patients with sickle cell trait, which is represented by this blockbuster sequel, The Sickle 2, Sickle Traitor, only one allele of their beta globin gene has the sickle cell mutation. Therefore, their hemoglobin electrophoresis will show a decreased amount of hemoglobin A and a slight increase in hemoglobin S. Remember that normally, people should not have any hemoglobin S, so when we say a slight increase, we mean that there's any present at all. Now let's move on to alpha and beta thalassemia. Alpha thalassemia, represented by the alpha reel of the Holy Chalice film, is a condition where the production of the alpha globin chains is disrupted in some way. Because there are 4 alpha chain genes, there's a range of manifestations of this disease. Said another way, there's a different disease for each time one of those genes is defective. We'll review alpha thalassemia major here, because you may see evidence of this in utero. Alpha thalassemia major is when there's 0 or just 1 normal alpha gene. If the fetus has no normal alpha genes, this is incompatible with life. Many fetuses die in utero or show hydrops fetalis on ultrasound or at birth. On a hemoglobin electrophoresis, each will show some level of hemoglobin Barts, which is just 4 gamma globulins instead of the normal 2 alpha and 2 betas. Beta thalassemias happen when there's impaired production of the beta globin gene. We'll remind you to think of them when you're screening anemia in pregnancy with this beta reel of the Holy Chalice film. Unlike alpha globin, which has 4 genes coding for it, beta globin only has 2. The hemoglobin electrophoresis of someone with beta thalassemia minor will show a slight increase in hemoglobin A2 and a slight decrease in normal hemoglobin A. Patients with beta thalassemia major will have no normal hemoglobin A and increased values of hemoglobin A2 and hemoglobin F. These patients are transfusion dependent. Moving on from the thalassemias. If your patient or her partner is of Ashkenazi Jewish heritage, the American College of Obstetricians and Gynecologists recommends carrier screening for 4 diseases: Tay-Sachs, Canavan disease, familial dysautonomia, and cystic fibrosis. There are many more diseases that are more prevalent in the Ashkenazi Jewish population, and expanded genetic panels are available to your patient if she and her family desire to be tested. However, only the 4 diseases we just listed are the ones that are formally recommended by ACOG. Now that we've gone over screening tests, let's move on to diagnostic testing. There are 2 main modes of diagnostic testing: chorionic villus sampling, also known as CVS, and amniocentesis. You would recommend one of these to your patient if her fetus screened high risk for a disease or if there was an abnormal ultrasound finding. Chorionic villus sampling is performed between 10 and 13 weeks gestational age, which is why this pop corn is underneath screen 1. A small portion of placental villi are aspirated either transcervically or transabdominally to provide genetic material for further study, such as karyotyping or microarray. If the fetus is between 15 to 20 weeks gestational age, then you can recommend amniocentesis for diagnostic testing, represented by this apple juice underneath screen 2. In this test, around 30 cc's of amniotic fluid is removed transabdominally under ultrasound guidance. The biggest risk of each of these procedures is pregnancy loss, though for each, the rate of pregnancy loss is still less than 1%. Well, now that the movie's done, nothing's left but to leave our review. First, we went over prenatal screening tests. Cell-free DNA, also known as the NIPT, or NIPS, can be done starting at 10 weeks and has the best Down syndrome detection rate at 99%. The first trimester screen, which is done between 11 and 13 weeks gestational age, consists of serum PAP-A and HCG values as well as a measurement of nuchal translucency. The first trimester screens for trisomies 18 and 21. The quad screen is done between 15 and 22 weeks gestational age and consists of serum levels of HCG, AFP, estriol, and inhibin A. The quad screens for trisomies 18 and 21 and neural tube and abdominal wall defects. An integrated screen is the result of combining the outcome of the first trimester screen with the NT measurement plus the quad screen. This combination will give you a risk assessment for the aforementioned genetic disorders. A serum integrated screen is the same idea, except without the NT measurement. Sequential screening considers the result of the first trimester screen and from there, either offers cell-free DNA screening or diagnostic testing if the result is high risk, or moves on to the quad screen if the result is low risk. Finally, prenatal diagnostic testing of the fetus involves either chorionic villus sampling or amniocentesis, which collects fetal DNA and then performs karyotyping or microarray on this material. After fetal genetic screening, we then went over parental carrier screening. Parental carrier screening for spinal muscular atrophy and cystic fibrosis should be offered universally, while carrier screening in the Ashkenazi Jewish population should also include tests for Tay-Sachs, Canavan disease, familial dysautonomia, and cystic fibrosis. If a patient is anemic and in a high-risk ethnic group, she should also be screened for sickle cell disease and alpha and beta thalassemia. And that's all, folks. Hope you enjoyed the show. Make sure to come back anytime you need a refresher. We hear this flick has a lot of rewatch value.
Your continued patronage is very, very welcome.